Good morning to you all. Today we'll be talking about ventral incisional hernias, etiology and repair options. Ventral hernia is also known as incisional hernia, and as per definition, it's a hernia occurring in a line of previous abdominal surgery. So a ventral incisional hernia is complex because it may be a hernia consequent to surgery, or it may be a recurrence after a repair of an incisional hernia. It's a surgery that is not that easy to be done, and it needs a lot of expertise, understanding of the anatomy, physiology, and the technical processes involved in the repair of incisional hernias. Now, what are the objectives of study in the case of incisional hernias? First, you should know a bit about the epidemiology, etiology. Anatomy is very important of the anterior abdominal wall because the entire development of the hernia depends on the domain or the functional integrity of the anterior abdominal wall. A good pre-operative evaluation of the patient, and we'll also discuss the operative strategies. There's been a lot of what you call advances in the management of incisional hernias. Now look at these hernias. This is actually what is referred to as a complex, what you call ventral hernia. Why do you say it's complex? Because the domain of the anterior abdominal wall is lost. That means the skin is stretched, the bowel is outside, it is just about to burst, the muscle tone is entirely lost, and there are multiple openings. These are what you call hernias, which are very difficult to manage, and they are referred to as complex incisional hernias. Or you may get a hernia at the site of surgery, a single hernia, which is often referred to as a simple incisional hernia. The challenge lies in managing these complex ventral hernias. Now, what is the definition of a ventral incisional hernia? Basically, it's a defect formed at a prior abdominal incision site. It may be a laparotomy, it may be a what you call fenestrian incision, or any incision over the abdominal wall. So basically, there's a dehiscence of the what you call abdominal wound, giving rise to a defect through which there's a protrusion of the abdominal contents. So basically, it's nothing but a defect formed at a prior abdominal incision site. Now, what is the incidence? Approximately, when you take the statistics, 4 to 5 million laparotomies are done per year, of which 4 lakhs to 5 lakhs develop incisional hernias. So it's not a very rare entity. There is a high incidence of incisional hernias. And every year, approximately 2 lakh incisional hernias are repaired in the world. And it's usually common after abdominal surgery, and the percentage-wise distribution is 13% of laparotomy incision. So you do a lot of laparotomies, high incidence of ventral hernias, and a high incidence of repair, and usually occurs after abdominal surgery. Now, why do you have to fix incisional hernia? Now look at the picture here, showing an extensive what you call herniation of the bowel contents. You can see the intestine, the skin is stretched, the muscles you can see the muscles completely what you call divaricated or away from the midline, and there's a big weakness. Now if you leave this, what happens? It can lead to obstruction of the bowel, incarceration, strangulation, intracutaneous fistula. Due to traction of the bowel, it can lead to chronic back and abdominal pain, and loss of abdominal domain or functions of the muscle, and due to the dragging sensation, there is a poor pulmonary function. So all these causes lead to the thought that ventral hernias have to be repaired. Why do they form? Every surgeon says I did a very good repair, but in spite of that, an incisional hernia developed. It's basically a multifactorial process. Technique is not the sole cause. That is why you need not blame the surgeon always when you have an incisional hernia. Probably there are other factors which are responsible for the formation of ventral hernias. They are primary and secondary facial pathology. Primary facial pathology is abnormal collagen metabolism and production and increased matrix metalloproteinase MMP activity. So collagen activity abnormalities can lead to primary facial pathology, ultimately leading to hernias. Secondary facial pathologies are due to the loss of normal tissue architecture and replacement of facial planes with scars. It may be recurrent surgeries, or the third one is mechanotransduction. Mechanical forces which raise the intra-abdominal pressure, stretch the muscles like coughing, straining during voiding or constipation, stretching of the muscles usually induce changes in the fibroblast function. And loss of this during primary healing leads to weaker tissues. So if you have a patient who's having cough, who's straining, they strain, what happens is the muscles get stretched and there is a weakening. Early laparotomy failure has significant incidence of recurrent hernia. That is why whenever after a laparotomy you develop a wound discharge or you find slight dehiscence of the wound, it's a warning sign that this patient can go into a ventral hernia. Now you have to know a bit about collagen 1 and 3. Collagen type 1 is mature collagen. It has great strength and component of extracellular matrix. So collagen type 1 is good collagen. Collagen type 3 is immature, weak, isoform and less cross-linking. That means it is a poor type of collagen. Now a low ratio of collagen type 1 to collagen type 3 have been demonstrated in scar plates of recurrent hernias. So basically, not only the technique but also the developmental collagen anomalies can lead to hernias. Now, wound healing biology. What happens in a normal wound? Healthy tissue is replaced by fibrotic tissue, which comprises of fibrinogen and collagen and relies in the formation of sufficient scar tissue. The crux is fibrosis with the formation of sufficient scar tissue. Now, when does a ventral inguinal hernia start forming? The cascade begins with early laparotomy wound failure. For example, you've done a laparotomy. The third or fourth day, you find a discharge from the wound in less than 11% cases. Those are cases which are prone to develop a ventral inguinal hernia. Or during the lag phase of healing, which is the weakest part. 94% patients develop ventral hernia within 7 years, and these represent occult dehiscence. And most of the occult dehiscences occur within 30 days of wound closure. Now, it's mandatory to understand the anatomy of the abdominal wall, anterior abdominal wall, because the pathophysiology of ventral hernias is based on the domain of the anterior abdominal wall muscles. You have 3 oblique and 2 vertical muscles. Which are the 3 oblique? External oblique, internal oblique and transversus muscle. And the vertical are rectus abdominis and pyramidalis muscle. Now, there is an aponeurosis arising from the external, internal and transversus, which fuses with the opposite side in the midline and forms the linea alba. whereas the same aponeurosis covers the rectus abdominis anteriorly and posteriorly, and it is referred to as what you call the anterior rectus sheath and posterior rectus sheath. This is a cross section showing the muscles, the linea alba, the formation of the aponeurosis, and then you have the rectus muscle with an anterior rectus sheath and posterior rectus sheath. Now, in the subdermal plexus, you have the vessels, which are the deep inferior epigastric artery, superficial circumflex artery, and deep circumflex artery, and you have the nerves also. The importance is that when you dissect or when you're doing a component separation, which I'll discuss later on, you have to be careful to maintain the blood supply as well as the nerve supply. Now, what are the, as I said earlier, this is what I said earlier, 5 paired muscles, 3 flat, 2 vertical, flat muscles. Now, increase in the abdominal pressure to facilitate defecation, micturition, and parturition, stabilizes the trunk. You have 2 vertical muscles, the rectus abdominis and pyramidalis. Rectus is the tensor of the abdominal wall, flexor of the vertebra, stabilizes the spine during walking, protects the abdominal viscera, and aids in force expiration. So each of these muscles have a particular role to play in the normal activities of the individual. Now, innervation of the abdominal wall is from T7 to L2. Nerves lies in the space between the internal oblique and the what you call and transversalis, and it is a risk of injury during component separation. Now, how can you predict the development of ventral hernias? The predisposing factors are obesity, pulmonary disease, wound infection, intra-abdominal sepsis, malnutrition, anemia, corticosteroid dependency, prior ventral hernia repair, collagen vascular diseases, and low CI-C3 ratio and elevated MMPs. This is a point which we have discussed earlier. So whenever you select a patient for ventral hernia repairs, you have to look into a lot of factors, particularly, what you call obesity, then pulmonary disease, wound infection, malnutrition, anemia, steroid dependency, etc. Because if it is not corrected, this is going to lead to a recurrence. Now, what are the goals of what you call ventral hernia repair? Now, your main aim is you have a distorted or a weakness or a defect in the what you call musculature. You have to restore the abdominal wall continuity, restore function to abdominal wall via recreating a linea alba with primary fascial closure. The most important thing is you have to preserve the blood supply and nerve innervation. It should be a durable repair with no tension, and the abdominal wound should be closed without tension. So the main aim would be to restore abdominal wall continuity. Now, this is what I said about the stability of the linea alba, which what you call the vertical muscles which support the spine, and this is what you have to achieve by doing a good surgical procedure. Now, we think of functional repair. Patients with ventral hernia have lower peak torque generation by hip flexors versus control. Functional repair has greater torque function than non-functional repair, and clinical utility of torque measure here is unclear. This is something which you don't have to think about, but only thing that you have to understand is a proper approximation without tension of the linea alba has to be done. Now, pre-operative goals. Every patient who's being taken up for surgery, you have to have certain goals as far as the pre-operative presumption is concerned. The patient should have an optimized patient physiology. Nutrition should be adequate. You should define the anatomy and the weakness. If there is any septic source, try to remove it. Identify the intestinal fistula. If there are any processes or meshes placed earlier, it has to be removed. Review all the operative reports for the previous surgery, the type of suture materials used, the type of complications that the patient had, how did the hernia develop, whether the patient has any complications or not. Review all the imaging, including the CT and MRI, which may give you an idea of where the muscles are and what the position of the muscles is. Weight loss, and another thing is smoking cessation, which is very important. All these pre-operative goals have to be achieved if a successful surgery is to be contemplated upon. Now, issues with repair. See, when you talk about repair, about 60 years or 70 years back, the repair was naturally nothing but anatomical repair. There's no universal technique for repair as far as ventral hernia is concerned, but today everyone does a functional repair, and there's a comparison with prosthetic covering. Now, functional repair means anatomical repair. You're opening up the hernial sac, reducing its contents, and approximating the muscles and linea alba. Whereas in a prosthesis, you place a prosthetic material inlay, onlay, or sublay. But for a primary suture repair or functional repair, the recurrence rate is very high, approximately 50%, whereas in mesh, it's approximately 2 to 36%. But I think it's a bit exaggerated figure because mesh repair is much better nowadays. Today, we don't talk of anatomical repairs, even for small defects, but today the primary aim would be to do a mesh hernioplasty. Technique, primary suture repair, not done. They say less than 2 centimeters, you can think of a defect, you can think of a primary, what you call this thing, but what happens is chances of recurrence are very high. You can do an open or a laparoscopic or an endoscopic procedure. You can do a nose separation with onlay, means placing the mesh over the what you call anterior rectus sheath. Sublay means between the what you call posterior rectus sheath and peritoneum, and inlay means below the peritoneum. Now, the last thing the component separation technique is usually used for complex hernias where the defect is large, you have multiple defects, there is loss of domain of the muscles and skin. In that case, you'll have to mobilize the whole what you call the muscles right from the subcostal region up to the what you call the pubis, and then place a full length mesh so that no recurrence occurs. There's another technique which people have been trying, Reeve-Stupa's retro repair, which is quite good. Autologous tissue repair with tensor fascial lata and what you call flaps, which may be pedicled or which may be a vascular flap, has been tried, but it's still in the experimental stage and the results are not that gratifying. Preoperative pneumoperitoneum is created in a what you call a laparoscopic surgery. Prosthetic repair, what we use is polypropylene. Now, if there's a peritoneal defect, use a dual mesh. One side is Prolene and the other side is Vicryl. The Vicryl side is towards the peritoneum because the Vicryl is non-irritant. The bowels will not get eroded and ulcerated. Whereas Prolene is mainly used as an inlay, onlay, or sublay mesh. Primary suture repair, they say it's less than they've said less than 5 centimeters, but an alteration would be less than 2 centimeters, transverse defect, but usually the recurrence rate is more than 50%, so the chances of recurrence are very high and the procedure is more or less abandoned. Sublay means you're seeing the skin, you're seeing the subcutaneous tissue, anterior rectus sheath, posterior rectus sheath, and peritoneum. And a sublay or a inlay mesh is usually between the posterior rectus sheath and the peritoneum, and an onlay mesh would be above, subcutaneous, over the anterior rectus sheath. Most of us do what you call an onlay mesh, whereas a sublay would be much better because it does not, it does not cause any infection or anything. But the problem is you need a lot of dissection. Okay, this we have already talked about. Onlay repair, mesh is sutured to the anterior rectus sheath. Advantages: it keeps the mesh separated from the abdominal contents. Disadvantages is wound repair under tension and mesh infection when surgical wound is infected. But the advantage here is if you have a mesh infection, it can be easily removed. All that you have to do is open up the wound just below the subcutaneous tissue. Over the anterior rectus sheath, the mesh is found. But if you place a sublay, what happens is the mesh is below the posterior rectus sheath. You need a lot of dissection, and as a result of which, there will be a lot of traumatizing to the tissue, leading to further problems. Inlay. That means here the sac is excised and facial margins are identified around the hernial defect, and the mesh is sutured circumferentially to the facial edge. What we use is polypropylene, but if there is what you call a large defect and a peritoneal defect, you use what you call vicryl mesh. And exceedingly high recurrence rate and should be abandoned in practice. Now, this is one of the repairs that most of the surgeons practice. Now, the posterior rectus sheath, as you all know, is deficient in the lower part of the abdomen. In the upper part, above the umbilicus, you have an anterior rectus sheath, posterior rectus sheath. Now, Stuper's technique is nothing but a retrorectus repair. This technique utilizes the hernian sac to separate the mesh from the intra-abdominal contents. Superiorly, the dissection is, performed above the posterior rectal. You lift the rectus muscle and dissect between the rectus muscle and the posterior rectus fascia above, and below you dissect the preperitoneal area, because that area is deficient of what you call posterior rectus sheath. This repair has a low recurrence rate. A large piece of mesh is placed in the newly formed space and fixed to the muscle layer above. This is a typical hernia. This is a hernial sac which is opened up and reduced. This is the posterior rectus sheath. This is the anterior rectus sheath. This is the muscle. The posterior rectus sheath is sutured here, and the mesh is sutured to the muscle and to the sheath here. A big this thing is placed here, and this is what is called as a Stuper's repair. The anterior rectus sheath is closed, and if there is a tension, you can give a relaxing incision above and to release the tension. Now, IPOM is a new technique, designated by the laparoscopic surgeon. What it means is intraperitoneal onlay mesh. Now, what you do in that is there's minimal dissection. With the help of a laparoscope, the hernia is reduced, and onto the defect, you're suturing the mesh. The mesh may be fixed at 4 sites, and rest can be fixed with tackers. And it limits excessive tissue dissection, less wound complication, lesser hospital stay, but the risk of bowel injury is very high, approximately 3.45%, and doesn't restore the function to the abdominal wall. Though laparoscopic surgeons are of the view that IPOM is good, it's a procedure that's not gaining much of importance nowadays, because people think that it is not restoring the function of the abdominal wall. This is basically what they do. There's a hernia here. The contents are reduced, and you place a mesh here and suture it. This is the hernial sac on the CT scan. What you do is you reduce the contents and you suture the mesh onto this area. What do you mean by what to do with significant loss of domain? I showed you the first diagram where there was extensive herniation, multiple openings, bowel out, stretched skin, muscles completely stretched off from the midline. In those cases, anatomical repair is not possible. Now, there are other methods to release the tension. You can inject laterally botulinum toxin, which will cause relaxation of the external, internal, and transverse abdominis muscle, and then you can do a sliding procedure. But that takes time. Or you can do serial excisions, which may require multiple operations. So today, gradual tension methods are not taken into consideration. Tissue expanders, which can be placed, and you expand the tissue and later on do surgery, and it's placed under the tissue to stretch with repeated installations. Advantage includes innervation, vascularization, and autologous tissues used. but disadvantages are 20% chances of exposure and infection rate and requires many treatments. It has been used to cover large defects. This is basically a large defect in the what you call anterior abdominal wall. What they have done is they have put tissue expanders, and later on they have what you call put a graft over there after repairing the muscle, and the graft is placed over there. This is the final picture after surgery. Now, autologous grafts using fasciolata and pedicle flaps. Flap selection is based on the location and arc of rotation. These are procedures not routinely done, but often a free fascial graft may work if you have a small defect. Now, hernia prophylaxis, placement of mesh at the time of index laparotomy is safe. That they say that if you have a huge obese patient with a large hernia, it's always better to place a mesh, and because the low recurrence rate after 1 year. And animal models with growth factor and cytokine injections into the abdominal wall or growth factor impregnated mesh after laparotomy decreases incisional hernias. These are all things which are assumed rather than done. Technical keys to success for prevention would be primary fascial closure at index laparotomy, 4:1 suture wound length, use monofilament non-slowly absorbable suture, 1 centimeter bites at 1 centimeter intervals. Now, this is actually the algorithm for treating what you call ventral hernias. You have a hernia, you assess the what you call defect, decide on the best approach, whether it's open or laparoscopic. It's often laparoscopic, do a mesh repair. If it's open, defect is small, you can place an onlay mesh or a sublay. Then if the defect is large for primary repair, in that case, you have to do a component separation. That means separate the muscles and then what you call do a transection of the transverse abdominis and slide the muscles into the middle and do a suturing. This is called as a component separation. I don't think as an undergraduate you're supposed to know much about component separation. It just means mobilizing the muscles and sliding it to give a tension-free repair. And the advantage is you can cover the whole anterior abdominal wall with a mesh, right from the subcostal area to the pubic symphysis, so that it covers all the hernial orifices, preventing the development of hernias later on. There is a posterior, what you call component separation, and an anterior component separation. Anterior means anterior to the rectus sheath, and posterior means between the posterior rectus sheath and the what you call the rectus abdominis muscle. But the only thing that you have to remember, be very careful, is vascularity and the nerves have to be maintained, or else there's a chance of recurrence. Conclusion: wound biology holds the key to lessening recurrence. Functional restoration should be the standard approach. All ventral hernia should consider reinforcement with prosthetic material. Suture repair and inlay repair of ventral hernia should be abandoned, and ventral hernia should be customized to each patient. That means if you have a simple hernia, do a meshplasty. If you have a complex hernia, the best would be do a component separation, mainly anterior or posterior component separation. Thank you, ladies and gentlemen, for the patient hearing. No, it's okay.